So welcome to Breathing Retraining in Chronic Disease. My name's Catherine Moffat and this is Rhys Hurst, and we're from the Cambridge Breathlessness Intervention Service, and we're both physiotherapists for this service. And we're going to focus today on breathing retraining in all sorts of chronic disease. We're going to start with a literature overview, and we're going to keep that quite brief because we want to get onto the practical side of things. Then we're going to look at breathing control, breathing pattern retraining, recovery breathing, and then go a little bit more deeper on that. But I know that you've already had some information on recovery breathing from this morning's lecture. Then we'll look at the literature around pursed lip breathing and then some good practice points. So when you do a literature search about breathing retraining in chronic disease, it is tricky. You've got things like breathing control, diaphragmatic breathing, paced breathing, blow as you go. Some people call it breathing exercises, breathing techniques, breathing retraining. It's very complicated when you try and do searches. But looking under different pathologies, we can see what sort of things are being used at this time. So for asthma, this is where the largest body of evidence is for breathing techniques. And they tend to focus on the Papworth and the Buteyko retraining methods. And the idea of these is to reduce hyperventilation in those with asthma. And they have been shown to reduce asthma symptoms, bronchodilator use, and improve quality of life. And in fact, the BTS sign and the GINA guidelines, both published this year, have shown that these type of techniques have a grade A rating. They've got the best evidence behind them, the strongest evidence base behind them. This isn't going to be the focus of the lecture, but it's just to make you aware that that is where the strongest evidence is for breathing retraining in asthma and in chronic disease. Moving on to COPD, the evidence isn't so strong in this area. A Cochrane review by Holland in 2012 showed that there was actually some evidence that it could improve exercise tolerance, things like breathing control and diaphragmatic breathing, but there wasn't really evidence for quality of life or shortness of breath. Often when breathing techniques are looked at in the research for COPD, they often mix the methods. So you'll use breathing control with pacing and with positioning, with pursed lip breathing. So there's a lot of mixture in the research which use. Okay. So studies such as Hotchesser and Wu, they looked at things like paced lip breathing, diaphragmatic breathing, panic management, and in Hotchesser they actually showed that shortness of breath was significantly reduced after stair climbing with things like diaphragmatic breathing, forward lean position, blow as you go, and pursed lip breathing, whereas Wu looked at techniques such as panic management, diaphragmatic breathing, and pursed lip breathing. So the actual guidelines on COPD and breathing retraining actually give it a grade sort of D evidence for things like breathing control and diaphragmatic breathing, and we will be looking into that a little bit later. So the evidence is quite weak in this area due to the mixed methods used, and possibly due to the fact that COPD is quite a wide range. You get some people who are very sort of mild in their condition through to the very severe patients, and when we talk about pursed lip breathing, you'll see how different techniques change depending on the severity. And we'll go into the review by Roberts later on. So looking at cancer, the guidelines, the NICE cancer guidelines in 2011 actually recommend with grade A evidence a package of breathing techniques be used to help manage breathlessness in cancer. And these include breathing control, psychological support and coping strategies. And these do reflect the literature from Corner and Bredin and Farquhar most recently, where they use just a mixed methods. So they'll be using anxiety management alongside these things, as well as the breathing techniques and the fan. And Farquhar, which came out quite recently, which was based in the Cambridge Breathlessness Service, looked at 54 patients with mixed cancer, so cancer of all different types, and distress-induced breathlessness was reduced significantly using sort of mixed methods to manage breathlessness. With interstitial lung disease, it's really hardly anything out there that I could find. It's very tricky. The very recent trial that came out by Higginson, they had 18% of their 105 patients had interstitial lung disease. And this trial, as Anna talked about earlier, actually showed that the distress-induced breathlessness was reduced. And interestingly, although survival at 6 months in this Higginson trial wasn't different for the cancer patients, for COPD and ILD, actually survival rates were significantly improved in that particular group of patients at 6 months. And again, this is looking at a package of measures, not only breathing techniques, but also pacing, positioning, fans, psychology, all these things. Then we look at chronic heart failure. And patients with chronic heart failure have been seen to hyperventilate. They increase their respiratory rate as soon as they start exercising, as Myers has shown, and they thought this was due to high pulmonary pressures and poor lung compliance. However, slow-paced breathing to a metronome actually reduced pulmonary pressure, reduced shortness of breath, and increased left ventricular ejection fraction. And this metronome thing, it's called the respiratory rate. Has anyone come across that? It has a little band that goes around your sort of lower chest, and that obviously measures the breathing rate. It's connected to a box which the patients wear, I think they were wearing it 2 or 3 times a day. And first of all, the first 3 minutes actually measured their respiratory rate. And then for the next 10 minutes, it gradually slowed the respiratory rate by using a 2-tone metronome. So it was a high tone for inspiration and a low tone for expiration. And it was the expiration that was lengthened to reduce the respiratory rate to below 10 breaths a minute. And they used this, I think, 2 or 3 times a day, and this is the results they got. So it's quite, an interesting sort of novel way of doing sort of breathing retraining, and the actual compliance was 90% in these patients. So people were very, interested in using this piece of equipment, and they liked to use it. So 90% of what the patients were asked to do, the sessions they were asked to do, were completed by the patients. Essential hypertensions. This is hypertension where there is no sort of known cause. They can't find a cause for the high blood pressure. This particular study showed that people with essential hypertension in the study had significantly higher respiratory rates but lower end-tidal CO2. So these people were hyperventilating at rest compared to the control groups who didn't have hypertension. What they got them to do is to breathe at 6 breaths a minute for 2 minutes and then 15 breaths a minute for 2 minutes. And this actually improved the arteriobaroreflex sensitivity and reduced blood pressure. And this reflex is actually what gives the homeostasis to your blood pressure. It actually keeps the blood pressure at an even keel. So that's sort of a quick run through of what kind of research is out there, what kind of breathing retraining is going on in different chronic diseases. So taking a closer look now at breathing control and diaphragmatic breathing. Are these two things different or are they the same? Does anyone have any views of these? Because in the literature they are almost used interchangeably. And that's kind of how it is in practice. But if you look at the BTS ACPRC guidelines, they're actually given 2 different definitions. And breathing control is normal tidal breathing, encouraging relaxation of the upper chest and shoulders, whereas diaphragmatic breathing is using the abdominal movement, reducing the degree of chest wall movement as much as possible. So they are different, and significantly so. Breathing control involves tidal breathing, whereas diaphragmatic breathing, when you read the research around it, it actually increases tidal volume, so it's a slower, deeper breathing. And it's important to differentiate between the two, and I'm not convinced in practice or in the research literature that people are differentiating these, and this is also adding to the confusion with the results of the studies and with our own clinical practice. So breathing control is looking at efficient muscle use. It's calming, it deters hyperventilation, it slows airflow speed, and it promotes even distribution. Whereas diaphragmatic breathing has been shown to cause asynchronous ribcage movements and mechanical inefficiency, and therefore increase the work of breathing and diaphragm fatigue. And this is not for all patients, but for people who are hyperinflated, the severe COPD patients. And these the Gosling and the Ditchman and Wilson were actually literature reviews on breathing techniques, and these were their conclusions. In one particular study they found 2 patients with severe COPD had a 20% discrepancy between one lung and the other with the amount of ventilation using deep diaphragmatic breathing. So there isn't really any evidence that diaphragmatic breathing reduces shortness of breath in COPD, and it's not recommended for severe COPD or hyperinflated patients. Whereas breathing control is recommended in the guidelines. NICE lung cancer guidelines, as we've talked about earlier, recommends it as part of a package of measures, and the BTS Associate and ACPRC guidelines say that it's okay to use breathing control at rest to help manage breathlessness. But again, the evidence for the COPD with breathing control, it was only given a D rating in the guidelines, so it's sort of low evidence, and I think that's partly due to the confusion of what you're actually teaching, and the fact that good clinical trials haven't been done. So let's look closer at breathing control. And when I teach breathing control with patients, and when I started teaching breathing control with patients in BIS, the patients that we see have all got sort of chronic conditions: heart failure, cancer, COPD, interstitial lung disease. So a very mixed sort of picture. And I started thinking that when you teach breathing control, you teach them to breathe from their tummy, which we'll go into a little bit more detail. You're trying to get that efficient breathing. But you say to patients, you know, you can't just flick onto this and use this sort of when you're breathless. You need to practice it, you know, a few times a day for a few weeks to get really used to it so you can use it when you are breathless. It's not a technique you can just pick up just like that. And then I started to thinking, well, am I teaching a technique or am I retraining breathing patterns? Because if you ask someone to practice breathing retraining regularly for a number of weeks, you will actually get perhaps a carryover into the habitual breathing pattern. So now I was thinking, well, what am I doing here with these patients? And the next question was, you know, if these people have got pathology that's making them breathless, can you retrain breathing patterns in someone who's, you know, the pathology is changing their breathing pattern? You know, is it possible? I've put here relaxed tummy breathing because I don't like the term breathing control. It implies effort and control. Well, in fact, it should be relaxing. It should be achieved through relaxation. So when I teach it to patients, we call it relaxed tummy breathing. And then I started to think, well, if I'm saying that some of my patients, you know, might benefit from breathing retraining, you know, is there a need to do it? Have these people got abnormal breathing? Have they got hyperventilation? So I thought I'd have a closer look at that and see what I could find. So chronic hyperventilation syndromes, everyone familiar with breathing pattern disorders and chronic hyperventilation syndrome, or heard of it or come across it a bit. It used to be called chronic hyperventilation syndrome, it still is, but other terms have crept up over the years, such as breathing pattern disorder, disordered breathing. And it's been defined as a pattern of over-breathing where the depth and rate are in excess of metabolic needs of the body at that time. And this can be that someone's literally just breathing too fast, breathing too deeply, or as that picture shows, their breathing pattern is very disordered. So they're taking a big breath, a small breath, they're doing a big sigh out, then a big cough, and a big sniff. So it can be quite disordered. And then I was thinking, do our patients with chronic disease have breathing pattern disorders? Is that adding to their breathlessness? So these are the sort of things that you might be familiar with. So this is an exhaustive list, but this is the kind of things that you might see in a patient who has disordered breathing. Now we have to remember that our patients also have breathlessness, they also have pathology, so some of these things could be attributed to their pathology, but some of it could be due to their anxiety and their stress of living with a chronic condition. You know, do these patients have breathing pattern disorders and hyperventilation on top of their current condition? So these are the sort of things you might want to look for in your patients. The sort of things you might see above and beyond what you would expect with that particular patient with their condition. One of the most common tests for hyperventilation, the Nijmegen questionnaire, which has been validated for people without conditions, but also it's been recently validated in this year for people with asthma as well. So it can be used confidently with those with asthma to look for breathing pattern disorders and hyperventilation. And you can see how some of those symptoms on there, the faster, deeper breathing, short of breath, unable to breathe deeply, I mean that could be happening because of their pathology, or it could be adding to their pathology and adding to their symptoms if they were hyperventilating on top. So if you've got someone who's short of breath because of their pathology and they've got a hyperventilation breathing pattern disorder on top, you can see how this can increase their symptom burden. So, you know, is it feasible to think that breathing pattern disorders and hyperventilation actually exist in patients with chronic disease who are breathless? Well, these are the kind of things that are going through some of our patients' minds. At night, if the wrong things pop into my head, I'm worried, how long are you going to live? And then you get breathless. So this is perhaps an evidence this lady is lying there, she's still, she's not breathless, and then she's having these thoughts, and then she's breathless. Is this person hyperventilating or having disordered breathing because of her anxiety? Another patient said, will it get worse? Will I get much short of breath? Can I manage it? Is something terrible going to happen? So they do have all these fears in their mind, and as Professor Banzit was talking about earlier, you know, the amygdala has been shown to be linked and lights up and is active when someone is breathless, that very primitive fight and flight response. And why might these patients have coexisting disease? Well, as we've already explained, the stress and anxiety and depression of living with a chronic, disabling and unpredictable, life-limiting and life-threatening condition. So when is the next exacerbation going to happen? If they've got cancer, they've got so many worries about the treatment, the side effects, the prognosis. These patients who are breathless with their chronic disease will have daily frequent episodes of breathlessness, causing them to use their accessory muscles and have a different breathing pattern. And if they have an exacerbation of their illness, then this frequency of breathlessness, it could be prolonged over days. So they're having these unusual breathing patterns, overusing their accessory muscles, and can this then lead to a habit that they don't switch them off afterwards? Musculoskeletal changing, so the shortening in the pectorals, and the sort of chin poke posture that you might get. And then cognitive misconceptions about breathlessness and breathing. So, do they think, I need to take a deep breath, or I need to breathe deeply, as Anna was talking about earlier, that idea that I need more air. So are they almost adding to this disordered breathing picture? And breathing pattern disorder prevalence is between 6 to 10% in the general population. But in asthma, it's been shown to be 29%. So people with asthma have been shown to have more prevalence of breathing pattern disorder. So if you just had patients with chronic respiratory disease, if you were comparing them to the general population, 1 in 10 could have a breathing pattern disorder. But it seems like if you've got a chronic condition, then maybe this could be higher. We are getting increasing referrals from our respiratory consultants for breathing re-education and for suspected breathing pattern disorder. Often in their letters they write the patient's got disproportionate shortness of breath compared to their disease severity, or maybe they're hyperventilating on exercise testing. And does it really matter whether you try and re-change these breathing patterns? Am I trying to make perfection in an imperfect world? Well, actually, metronome-guided hyperventilation at twice the respiratory rate has been shown to cause dynamic hyperinflation with COPD patients at rest. So they had to sit there and hyperventilate with a fast respiratory rate, and they actually did sort of dynamically hyperinflate on top of that, and that increased their breathlessness. So, it does add to the condition, it adds to the breathlessness. So it can add to the symptom burden. So looking at breathing control as perhaps breathing retraining. So we're looking to create efficient breathing. So what is efficient breathing? We can split it up. So appropriate muscle use. So we want to decrease inappropriate inspiratory and expiratory accessory muscle use. And when I say inappropriate, if someone has got quite severe disease, they may have to use some of these accessory muscles. That might be part of that pathology. That might just be what they have to do even at rest. So you've got to try and, we'll talk about how we can actually change and look for these, what we can change and what we can't change. But it's inappropriate inspiratory and expiratory use. I'm not looking for perfection, but what can we reduce in these patients? We're trying to get them to focus more with their diaphragm, which doesn't get tired. Looking for an efficient pattern. So the expiratory phase should be longer than the inspiratory phase, at about 1 to 1.5. End expiratory pause, there might be a short end expiratory pause before the next breath starts, and we should try and look for that pause. And if patients are comfortable, try and lengthen that pause, because that will help slow the respiratory rate. And the breathing pattern should be quite even, so we don't want all these coughs and sighs and sniffs and big breaths here and then a small breaths, and it needs to be relatively even. They're not robots, some breaths might be a bit bigger than others, but in general relatively even. And appropriate volume and rate, so appropriate tidal volume, appropriate respiratory rate, making sure they're not breath stacking, so appropriate functional residual capacity. Are they breathing at high lung volumes when they could actually breathe a bit more in the middle where the lungs are more compliant? And nasal, are they breathing through their nose if possible? A lot of the breathless patients can actually breathe through their nose at rest. I know when they get very breathless when they're exerting themselves that maybe isn't possible, but at rest they should try and bring themselves back to a nasal pattern. It helps slow the speed of air, reduces the volume taken in, and also it warms, filters, humidifies and cleans the air, so it sort of helps protect the lungs too. So that all makes sense, but how do we teach it? So when I teach patients breathing control, or when I'm looking to change their breathing patterns, I always start by doing a bit of education with them, because they need to know what is going on and where things are and what things do. So I actually show them these pictures. This is to show them, and I talk a bit about what the diaphragm does. I demonstrate the diaphragm movement. I perhaps show them on myself how my tummy comes out when I breathe in, how it falls back when I breathe out. I might sort of demonstrate that with a bit of paper so I can show them where that movement is happening. And I explain that the diaphragm, it is fatigue resistant, it doesn't get tired, it can just keep going. And the diaphragm only moves about 1 centimetre, as Annie said, at normal restful breathing. During exercise, it may start moving down 7 to 10 centimetres, but at rest it's only 1 centimetre. So it's a very subtle movement. Then we look, then I talk about the accessory muscles. So I say the diaphragm's where it's very efficient. These muscles will help you when you're very breathless. I might talk about the Olympic athlete at the end of a race breathing from up here, but actually, you know, they're good for short periods to help you when you are very breathless, but they need to be switched off afterwards. So you don't want to be doing a press up with every breath if you don't have to. So I show them a picture of where they are and maybe explain why they might be getting some tension and chest tightness and discomfort around here, and explain that these are the ones we want to try and switch off and relax if possible and try and focus on the tummy movement. And then we've got the accessory muscles of exhalation. So this is where the abdominal muscles contract to help the exhalation. And in very severe COPD patients, this abdominal contraction may be happening even at rest. So again, is this something you can change or is it not? But if you can calm it down, then that's a good thing. So you're trying to see what you can calm down. And then I show them the wave of relaxed breathing. So this is something Anna talked about before, the 3 R's, the rise of the tummy as you breathe in, the relax of the tummy as you breathe out, and then there's a rest where you rest in the pause and wait for the next breath to come. And I'll draw this picture and explain that the out breath should be as passive as possible, and that's why it's longer. And this is how I would split things up. Because if you're trying to see what you can change and what you can't change, it's sometimes best to have a bit of an order. So you only change perhaps one thing at a time. Now, I'd work my way through this. I would probably never really get through the whole thing in one session. I might even just perhaps get past the first box in the first session. I might come back a week later or a few days later, and we might get a bit further down. And then again, I might come back a week further, and we might get further down this list. But in fact, it's, you know, some patients may never get right to the bottom of the list. You know, you have to sort of work for what those patients can do, work within their limits, and don't try and force them past what isn't comfortable. Just take your time. And some patients might not want to focus on breathing. Like Anna said earlier, breathing should be subconscious. So for some people, focus on their breathing, it just makes them feel very anxious and very uncomfortable. So for those patients, you might want to go into general relaxation techniques. Some patients might have a block, you know, a psychological block where they're very fear of dying or being very breathless, and maybe those sort of things need to be addressed and those questions need to be answered before the patient can move on and getting their breathing pattern back, because there could be other things that are keeping that breathing pattern going. But this is how I would sort of go through it, and at the beginning, posture is key. So as Anna said earlier, if you side lie someone, that seems to relax everything, particularly relax off the abdominal muscles and allows them to feel that breathing movement. So if I can't get someone to do it in sitting, I might get them to side lie. For some patients who can lie flat, I sometimes get them in the Alexander position, you know, with the books under your head. You put your hands on your tummy, so you lie on your back with your knees bent up, hands on your tummy, and you just lie on your back and feel the breathing movement that way. If everyone just takes a bit of a pause for a moment and just puts their hands behind their heads, and just have a little feel about how your breathing feels. And just have a little think. Are you breathing with your upper chest or your abdomen? Just take a moment to think that through. Okay, and then put your hand down. Now there's no right or wrong answer. Who was breathing more with their upper chest and who was breathing more with their abdominals? Who about upper chest first? Anyone breathe more with the upper chest with their hands above their heads? It's okay, you can put your hand up, it's good, it's fine. Anyone else? We just got one. And who was breathing more with their lower chest or abdominals? Okay, and who wasn't really sure? Okay, what about if you put your hands behind your back? So put your hands behind your back, either behind the chair or behind you. And have a think about where you're breathing from. Is it upper chest or lower chest? Some people might have to put their hands behind their chair. What do people think? Upper chest? Yeah, and lower chest? Yeah, so that's more half and half. This is an unusual group. I've done this with loads and loads of different groups. Usually it's half and half for both. You know, half and half for this one, half and half for that one. It was unusual we only had one person who was brave enough to put their hand up that time. But with other groups, we've usually got half and half. And what this is trying to say is that different positions will affect people differently. Now, I wouldn't actually get someone to sit through and do the whole breathing technique like this, or like this if it's uncomfortable. Sometimes if you're really struggling to get them to breathe with their tummy, I would just say, look, let's just do this for a bit and see what happens, and just see what they notice, just so they can get that feel for it, and then perhaps get their hand on their tummy. It's just to make them sort of realise what they're trying to feel and get it to happen. But side line is usually the way I go, like Anna said earlier, lying people on this side is usually the thing that really gets them to feel their breathing movement. And one lady, I just laid on her side, I said, put your hand on your tummy. Then we just talked about something completely different for a few minutes, because she was getting so anxious about trying to get it right, some of them try too hard. And then after a few minutes I said, oh, can you just notice what's going on with your tummy there? And she was breathing beautifully with her tummy, but because she'd stopped trying, she'd stopped trying to do the right thing. You know, it just happened by itself. So as the sort of the founder of the Alexander technique, if you stop doing the wrong thing, the right thing will happen by itself. So sometimes just trying to get patients not to try too hard, and for you not to try too hard, because you can both get very stressed with each other. So, talking about stress, shall we all practice this technique? And I'm going to talk you all through it. So get yourself comfortable in your chairs, feet flat on the floor, posture nice and comfortably upright, supported in the chair. You can close your eyes if you wish, because there's not going to be anything to see, and some people might help them to concentrate. And just start by scanning through your body. So start with your feet. Make sure they're comfortable on the floor. Check there's no tension in your feet. And at this point you might just want to put your hand on your tummy, your dominant hand, just above your belly button. And just make sure that elbow is dropped back in again, so it's not sticking out from your side. Starting with your feet again, they're relaxed. Your knees might be slightly turned outwards, so you're not clenching your legs inwards, they're just gently rested outwards. Your back is supported and comfortable on the chair. Your shoulders are dropped down and back. And your upper chest is just relaxed. Just allow your chin to drop slowly down, just so there's a slight dip, so you're not sort of poking your chin forwards. And your tongue should rest behind your top teeth, just so that your jaw stays comfortable and relaxed. And just feel through your body from your feet to your legs to your back, any areas of tension or discomfort. Have a little wiggle if you're not comfortable, try and relax and allow that tension to ease. And if it doesn't, just accept that and move on. Just accept it as a sensation. Don't give any onus to it or emotion to it, just move on to the next. And now just feel the breath moving in and out. Just notice the cool air coming in and the warm air going out. Don't try and change anything. Just notice what is happening and accept it. Don't judge it. Now if you feel comfortable with that, you might like to just notice the warmth of your hand on your tummy. And as you breathe in, that hand may rise slightly, and it's not a big movement. Remember that diaphragm only moves a centimetre. And just notice as you float the air in, the hand just moves gently forwards. And as you relax out, the hand drops down again. And as you breathe in, the hand rises. And as you breathe out, you relax and let the air come out in its own time. So rise and relax. Rise and relax. And if you want to, with every out breath, just try and deflate the upper chest a bit more. Try and let those muscles drop and release just a little bit more to allow that tension to ease. Just deflate as you breathe out, and then gently float the next breath in. So rise and relax, and allow the out breath to lengthen. Allow the out breath to lengthen until its natural end. And now just listen to your breathing and make sure it's nice and quiet, nice and gentle, nice and slow, no effort. You don't have to be perfect. It's just like waves on a beach. Some waves might be bigger than others, some might be slower, but they come in their own time. And if you're comfortable, you might notice there's a slight pause after you breathe out. Just notice that pause. Don't try and change it, but just notice that it's there. And if it feels okay, try and rest in the pause. You're not holding your breath, you're just staying there in that peaceful moment and waiting for the next breath to come. So you're not rushing into the next breath. So rise the tummy, relax the out breath, and then rest in the pause. Rise, relax, rest. Rise, relax, and rest. And just stay with that gentle feeling, that easy breathing, and notice how comfortable it can be. Okay, if you want to open your eyes again now. Is everyone feeling okay after that? We will be trying to practice that a bit later. But sometimes the waves on the beach giving patients permission that they don't have to be perfect, they're not a robot. You know, there will be some waves bigger than others, some breaths bigger than others. But that's okay, you know, allow them not to be perfect. And I wouldn't normally go through that whole thing like I did with you just then. I would work through that over a number of weeks or days, depending on how well the patient was coping with each level, and I wouldn't necessarily go through all of that with every patient. And for some patients I might pick certain areas, so I might start at the thing that I like the least about their breathing, or I think is the most dysfunctional about their breathing, and perhaps get them to focus on the tummy breathing and then look at reducing the volumes. Or if I think someone isn't pausing between their breaths, we might start looking at the pauses first, so I might change the order of things. If I think someone's breathing quite noisily and quite rapid in and out respiratory rate, then I might try and get them to listen to their breath and try and make it quieter, because that helps slow the breathing and helps sort of slow the flow. Again, if someone's got quite a fast respiratory rate, lengthening the pauses. If someone's breathing at high volumes, then you might try and just get them to breathe a little less. So you don't have to go in that order either. I do think the posture and getting it onto the tummy and relaxing accessory muscles, you should always start with that. But after that, you can play around with the pattern and start where you like, really. That order seems to work quite well, but you know, it depends on your patient. You don't have to stick with that complete model. So I'm going to pass over to Rhys.
Maybe not all too relaxed after that. But just an interesting practice point is when I joined this team, so I'm new to this team, but I'm doing breathing for a while, that it took Catherine just about 5 minutes to go through that with you. And it seems like quite a long time when you're doing it, or I used to think I never had time to do it properly. But actually it took 5 minutes. Granted, you're not patient and you haven't got those awkward questions yet. But again, it's quite interesting to think it only takes 5 minutes to do it through. Right. So from this second part of it, we're going to look at the recovery breathing. So we'll look at breathing control, which is about managing sometimes that shortness of breath, mild or moderate. This is when you're looking at someone who's quite severely, acutely short of breath. Maybe sometimes you've just found them, I don't know, generally on a ward you find them, they're in the toilet, they're struggling to get their breath back. These are the techniques to use around that. And we'll look at pursed lip breathing to support it, and good practice points again. Now recovery breathing initially was from a hospital in Canada, and it was a bit of a process, and actually what happened with this is they tended to just shorten and make it a little bit more succinct for patients, because they are in acute distress and they're breathing quite bad. There's quite a lot to take in, so it's important to try and look at reducing that. So the 3 F's was developed, and again it's about when you've got shortness of breath on exertion, panic, you want to get them into their breathing control, what can bridge the gap. And I often like the Alexander phrase that by not doing the wrong thing, the right thing will happen. Okay, so again, just by taking the focus a little bit away, can sometimes allow them to do the right thing. And again, it's one way of working, so we know the fan, which Anna talked about this morning, the forward lean position, which again, we always have to look at patients as individual, but there's a basic point to do with someone. It's been shown to actually reduce the muscle activity of your scalenes and some of your accessories, and actually put your diaphragm in that sort of length-tension relationship to allow that ventilatory sort of capacity to improve. And again, focus on the longer breaths out. Now again, we modify that depending on the patient, but the principle is there that when you're in that panic state, you'll want to keep breathing in and in and in. So just by trying not to do that, the right thing will happen. And we'll look at a bit of dynamic hyperinflation, which is sort of discussed today as well. Interestingly, in the King's College Hospital, their Breathlessness Service, they use a breathlessness poem that their patients work through. So again, and what we sort of look at this and quite like, that they talk about the drop the shoulders. So sometimes we think that with our 3 Fs, we should maybe put what we call an extra F in there, a flop, so you flop down and really take away what the accessory muscles are doing to allow that breathing to come through. It's just another nice way to look at it, and again, depending on patients, they might prefer along this way, and flashcards we use to support a patient when they're in that state to just focus on that area. From the fan point of view, it was talked about this morning, but I think it's really interesting, the fan, about having time just to go through it with someone and even just to go through the evidence behind it. And again, quite clearly it's shown earlier that in patients that aren't hypoxic below that 7.3, that giving them air or oxygen, and they didn't know which they were getting, would alleviate their breathlessness. And other studies have shown by changing the way they delivered the air, so by using a mouthpiece so you don't stimulate those sensors, or making the air hotter, again, increase the patient's perception of breathlessness. So the fan is a really useful tool. And we like it at the beginning as a bit of we like to call it a quick win as well for patients. And again, the belief that you're looking at sort of where the trigeminal nerve is and stimulating these nerve endings. But again, people find benefit on the side of the face. It doesn't always have to be directly on. And we always used to think there was no adverse effects to it. We had one patient recently said his nose was dripping a lot after using it, but on reflection he was probably using it straight up his nose. So yeah, so again it's about 10 to 15 centimetres, that small ruler away, and just using it. And again, the study by Higginson looked at it, didn't always have to use a fan, they used cooling, so they actually used a bottle that you could put droplet water in and just spray the area as well. Okay, so it doesn't always have to be the fan. But again, explaining the theory, looking at how it can benefit and the evidence that's there, patients can really get on with it. And the Galbraith study showed some patients got a benefit after seconds, but some took a few minutes to actually get it, so even 5-10 minutes to feel the benefit. But actually, the benefits lasted for an hour if they maintained at rest, or until they exerted themselves again. So actually the benefits they can feel for quite a long time as well. But again, I think it's a part of the process that you're just altering that afferent information. You know, you're just taking that, using different sensors, using different information, just to reassure that part of your brain that's sensing it, that it can allow its breathing to calm down. And it's good for someone to focus on as well. Now again, positions to ease breathlessness. So we talk about sensations of breathlessness, so sometimes the respiratory muscles feel they're not able to do their job they can do. So we want to make them feel that they can do their job, so using positions to do that. Now again, there's lots of muscles which help us breathe, and Catherine's already talked about the diaphragm, but again, you have accessories help with inspiration, and the accessory muscles for expiration. And again, it's looking at those muscles and which ones those patients are having to use at the time and which positions will best suit them. So intuitively, they might be doing something different. So again, the 3 Fs can work, but you might want to adapt it to your patients. So we know about the diaphragm. It's looking at the accessory muscles and looking at the fibres, basically, the angle of the fibres, because that will look at the pull of the muscle. Okay? So generally, we know a little bit of the pecs, and your latimus dorsi and serratus anterior have a better pull if your arm is passively fixed and generally slightly higher. Okay? So just by putting those muscle fibres in a good position, you'll improve that capacity of that muscle to work, as well as if you're using something for the diaphragm as well. So it's looking at what your patient's already doing, and sometimes just reassuring them that they're doing the right thing. You know. And again, with exhalation, you know, you use the abdominal muscles as well, and just the slightly forward lean. Sometimes I even just encourage a little bit of a just what I call a pelvic tilt, just a little bit come forwards, because we all know that you get the tipping point too far, going down too far, they feel like they're squashing their diaphragm as well. And if you are generally hyperinflated and that's flatter, then that could be causing a problem as well. So it's just looking at what the patient is doing. Sometimes it's a very altered tilt with supporting of the arms can make a big difference, and even getting the arms supported right into the axilla. So it's passive fixation. So again, it's not all forward lean positions, statically onto the side, so using those muscles, even the arms behind the head, although they might not find that comfortable for long. Leaning forwards, just again, utilises the different muscles they're having to use to allow them to breathe more effectively. So it's about, picking what's right, and it improves the contractile properties of the muscles, or hopefully allow the muscles to work with a better contraction. They have more time to work and a better length tension, so actually they'll reduce their lung volumes a little bit as well and be able to breathe a bit better, and that colliery discharge will be better from the point of view that the afferent information back, the muscle will feel happier in what it's doing in a simple way. And even from a side point of view, that even a nice sideline position, and even we'd probably argue that the arm on the sideline position could even be a little bit higher to really help those posterior muscles kick in. And walking aids, actually there's pretty good evidence for walking aids, especially with COPD patients, actually enable them to increase the distance they can walk and how it can do that. And also it can be a confidence builder, it can slow them down a little bit as well. So don't underestimate a simple tool can actually help their patient, what they're managing and how they're doing. Now, focus on the breath out. So if we're looking at the COPD patient, the hyperinflation pathologies, so again, we're hoping to stop that dynamic hyperinflation, which unfortunately just that extra volume makes your lungs feel quite restrictive. So again, that will add to a sensation of breathlessness. Your diaphragm not being able to work as effectively by being flattened. So again, these will add to a sensation of breathlessness. And again, to get them out of the pattern of that in, and just focusing on that breath out and lengthening the exhalation time, adding in pursed lip breathing, which we'll go into a little bit later as well. We're really looking to deflate that upper chest and even actually putting hands on patients to really try and get them to take that air out of that top part of your chest. And passively it can work well with patients, and we use it sometimes in breathing retraining just to get them out of that sink of here and bring them down into here. Because we do know there's a strong correlation between exertional dyspnea, end expiratory lung volumes, and inspiratory effort to that volume displacement. So again, it is very uncomfortable for patients, and explaining it to them can sometimes allow them to see what they're doing. And again, like Anna used at the slide today. And again, interestingly, that just on normal patients or normal people with such that rapid shallow breathing, your percentage of your tidal volume into your dead space is huge. So just by increasing that respiratory rate, although you're maintaining your tidal volume, or your minute volume, sorry, that dead space you're just ventilating in. So it's going to be very uncomfortable for them. And the non-hyperinflating pathologies, it's about relaxing that breath out. So not forcing it, not prolonging it, just letting it relax. Importance of switching off those accessories. So get that good position for them. And the good practice points that we've found, especially restrictive conditions, so because your pulmonary fibrosis will notice even a sense of suffocation if you're trying to prolong that exhalation as well. So it's about just altering it slightly, and even lung cancers, it can sometimes, if you prolong the expiration, can bring on coughing. And interestingly, from our talk this morning, the interstitial lung disease and the lung cancers had high frequency of cough compared to these chronic cough patients. So maybe they just have that sensitivity by changing that flow that they're not able to tolerate. So it's relaxing that breath out is important. And then we do have the sort of the hyperinflation and the panic side. So again, they can lengthen or relax that breath out. But important on deflating that air and just release the tension. So that drop and flop works quite well as well. So even back to that breathlessness poem about just dropping and flopping can work really well, just to allow patients to not do the wrong thing and the right thing will happen. But again, still you want to avoid a forceful expiration with some of these patients because they do have symptoms of air hunger. You may make that worse and just sort of exacerbate the panic that they're feeling. So pursed lip breathing. So again, pursed lip breathing has a wide amount of evidence supporting it, or evidence that's done on it, I should say. And again, it's just generally exhaling through partially closed lips, so you're building up this back pressure and getting this slight amount of peep. And again, there's a good systematic review done at the Hertfordshire University by Robert Tudor, and even through there looking at the information, that people explain it in different ways. So again, it's hard to compare what they're looking at a little bit. Some it's twice the exhalation, or twice what the inhalation is, 4 times what the inhalation is, or just to the end of your natural breath. So sometimes it's it doesn't always match up and there's a bit of difference about it, but even just prolonging that out breath, allowing that fresh air to get in basically. And sometimes I explain it to patients that I just imagine their lungs a bit like shopping bags. And they're going to breathe in and put 5 apples into those bags, and when they breathe out, they'll take them out. But then literally, if they don't breathe out enough, they'll put 5 in, only take 3 out, that leaves 2 in there. And what they're trying to do then is put 5 in on top of that 2. And anyone that's done any shopping knows to fit that extra thing in a full bag is really difficult. And again, I just try and keep it really simple, mainly for me, but again for their patients as well, just to avoid that from happening. So prolonging, allowing the fresh air to come in. But again, this study looked at about 54 articles, 11 were okay evidence, but again, it's given a grade C on the BTS and ACPRC guidance in 2009. And it's good to explain it to patients, because often carers notice that they think, well, they're not breathing right, it's huffing and puffing all the time. And actually that they may be doing it for a good reason, for this personal breathing and maintaining this PEEP, and even that end-expiratory grunting that some patients can do as well. Just explain to them they're doing the right thing, rather than being sort of, we put it in the book as being nagged at, but I don't always like that. But yeah, but that's the idea. But again, generally it's instinctive pursed-lip breathing and breath. At rest with people, they found that those patients had greater hypercapnia, lower exercise tolerance, lower diffusing capacity, they were generally more hyperinflated, and had a greater resting breathlessness. And again, the theory and explaining it to patients is sometimes like you've got a hose, you occlude the end, the pressure will build up within that to allow more to get out. And the potential benefits found in that systematic review, you can decrease the respiratory rate, increase tidal volume, increase saturations, hopefully leading to decreased exertional breathlessness, increased recovery speed, and increased functional performance at 3 months. But there's still been debate of if you can teach pursed-lip breathing or not. And studies have actually been mixed. Some people have taught it, and 3 months later patients were still getting benefit, and some studies have shown they teach it and they'd stop doing it once you stop the sessions. So again, it's generally on patient, or selective patient. If you can actually increase your work of breathing by adding to that resistance. So again, it might not work for every patient, so it's getting that balance right. So it has to be just enough narrowing of the lips. And again, studies have suggested using oxygen saturations as biofeedback, so popping on, hopefully what they do pursed-lip breathe, their oxygen saturation should improve. So some people use that as a way to teach them that they're doing it right, and they can go home and practice it with oxygen saturations as well. And again, just simple tips that are recommended in the guidelines. Again, avoid breath holding as a good practice point. Blow as you go to stop that breath holding. So when you're doing activities, on the forceful bit to do the expiration. And again, paced breathing. So again, walking upstairs, taking steps, and just balancing it out from there. So it's picking the right thing at the right time. And again, we've talked about breathing control, we'll practice in a minute. Recovery breathing and the pursed-lip breathing. So it's picking it at the right time, and even including, again, recovery breathing and pursed-lip breathing to benefit the patient. So with our patients, it's all pathology and lung mechanics. You need to suit it to the patient and be specific with it. The severity of their condition, breathlessness versus the anxiety and panic component. Look what they're doing already, those intuitive strategies they're doing, their coping mechanisms and supporting those. And again, sometimes it's trialling it and modification, just like Catherine said, even going through breathing control, it's just starting at the top and working your way down and seeing how you get through with it. Right. So we thought now about just giving you an opportunity to practice the breathing control and have a go, maybe even in just pairs, or the person you sat next to. Just have a little go at the language you use, the position you use, or even any questions you've got about what we discussed. Because really, we do it one way, but again, it's about what people find themselves works or doesn't work. So we've got about 10 minutes to do that.
I have a question, and I don't know, in honesty, how absolutely relevant it is to that. I'm not going to ask the first thing, but it is about breathing control. It's about managing end-stage, rapidly progressive breathlessness in the group of patients I see the most of the RPF patients. And those techniques around breathing control and having people see a benefit over a number of weeks, how do you manage those patients who are not going to see a benefit over a few weeks because you're accelerating their oxygen, they're declining rapidly, and how do you manage their breathlessness?
I mean,
have you got any ideas?
Again, to open it up to see, but again, I think it's... Sorry? No.
No, I want me to answer.
Sorry?
Do you want me to answer?
Yeah, go on. Yeah, what's fine.
I was going to say that if someone is at the very end of life, and you know, in the last few weeks or even days, we wouldn't necessarily use breathing techniques as a technique of choice. I'd focus more on positioning and the fan and pharmacological methods. Breathing techniques as such, you know, they do take time to establish, and I think when they're that sort of severe and end stage, I'd focus on
But for the IVF patient, I've got a lady in mind who I met in April, and she's got progressively worse over that period of time. But at no point along the way has she had a stable period when we could have built on techniques. Maybe we're not addressing it in the right way. I don't know. That's why I'm asking the question. But I don't know that she's going to die in weeks. She might be more months yet. But she's certainly got disabling symptoms that.
And is that definitely pathology led, the breathing pattern? Or has she got worries and concerns about end of life
as well? But she's got very severe restricted disease. I just think they're really difficult to manage.
I had a similar lady, and I did try and retrain her breathing pattern. When I was with her, I could get some lovely patterns. As soon as I left, she just couldn't continue without me being there. And after a few weeks, she did disclose that she was so scared of being so breathless that the breathless would be out of control near end of life that she'd actually saved up paracetamol tablets, and she'd rather take her own life than be that breathless in the future. And her overriding thing was her anxiety to live alone. So the reason why the breathing retrain didn't work with her, because she had so many fears about end of life and breathlessness. With her, we tried to use more just general relaxation techniques, and we got palliative care involved, and we started looking at pharmacology with her as well. But it is tricky because they can be progressively worse, and like I said, they can go on for months. But they are very tricky groups to manage. I completely agree. And whether there is some psychology that what they're worried about in the future as well.
Thank you.
Does she do anything to help at the moment? Does she find anything she does herself intuitively that you could build on?
She's quite resistant. This particular one is quite a resistant lady to most of what we suggest. Ironically, she's just wound up in hospital in crisis 3 weeks ago, and I think she's better now. And maybe that's to do with that. Maybe that's to do with being around and much more intensive attention than she's had. She's got a husband at home. Husbands, bless you, they can always help you. Sometimes they make it worse.
I suppose changing her breathing pattern, is it because, will that actually change the breathlessness? She might still be just as breathless, so it may look an awful pattern, but for the patient outcome, what is important to them is that will it make a difference to her quality of life?
Yeah, Catherine's point looking
at. It sounds like exploring the difference that you saw with her in hospital compared to when she was on her own at home, and see if you can identify, maybe talk a bit more about what she fears and so forth, or reflecting back to her what you're seeing. I think that's probably where I go, tending to focus, because anybody in that situation where they know where they're headed, their anxiety and fears and obviously almost inevitably going to be increasing, whether they can acknowledge that or not. Focusing on something.
just knowing what she wants to, what's affecting her, what she wants, what are her goals and things, and trying to go on that, because like from a health coaching point of view.
Use the same techniques with different disease groups, with the exception of not looking at extending the respiratory phase. Is that, in principle, you're using the same sorts of techniques with different disease conditions?
I suppose in principle, because it's a complex thing, we use complex interventions, but we're using lots of different things as well. So she might just find the fan more beneficial than actually the breathing control. So it's focusing on that, and it's allowing her to, to make a difference in what she wants as well. But it's, because we use so many things, we're trying to focus on what the BTF part of them is, if it's breathing, thinking, or functioning, and trying to break it down that way.